This content is not designed for use as a medical reference to diagnose, treat, or prevent medical illnesses or trauma. If you have questions about the diagnosis, treatment, or prevention of a medical condition or illness, please consult your personal physician.
Welcome back, everyone. In today's lecture, we're going to examine epilepsy, which is a disorder where seizures are the primary symptom. A person must experience 2 or more unprovoked seizures to receive a diagnosis of epilepsy. To picture a seizure, imagine groups of neurons in the brain all firing at the same time. Many people conceptualize a seizure as an event that occurs when there's a distortion of the normal balance between excitation in the brain and inhibition. Without this normal balance, neurons can fire erratically, creating instant chaos that presents itself in a variety of ways. A seizure is a sign that something is wrong in the brain and that further medical investigation is necessary. Today, we'll explore different categories of epileptic seizures, possible causes and treatments, and associated neuropsychological deficits. We will also examine 2 very different case studies. The first concerns a man named Henry Molaison, or HM. HM underwent an experimental brain surgery for epilepsy in 1953. He's actually one of the most famous patients in the history of cognitive neuroscience. The second case study is about a woman named Christine who underwent brain surgery in 2002 in an effort to control her epilepsy. These 2 case studies will help show how epilepsy can affect people differently. Let's begin by examining the different categories of seizures associated with epilepsy. One category is generalized seizures, which involves activity in both the left and the right hemispheres of the brain. The 3 primary subtypes of generalized seizures are tonic-clonic seizures, absent seizures, and atonic seizures. Tonic-clonic seizures, previously known as grand mal seizures, are the ones we typically think about when we envision a seizure. Here, a person experiences what's known as bilateral symmetric convulsive movement, the stiffening and then jerking of all limbs, along with a loss of consciousness. This is typically followed by a deep sleep. Absent seizures, formerly known as petit mal seizures, are quite different. Here, a person experiences a sudden lapse of consciousness that is often barely visible to the observer. Such lapses may include eye fluttering, stopping mid-speech, staring blankly into space, or head nodding. The third subcategory of generalized seizures is atonic seizures, also known as drop attacks. These involve the loss of muscle tone, often resulting in a head drop or fall. So those are the generalized seizures. A second category of seizures is called focal seizures, which used to be called partial seizures. Unlike generalized seizures that involve both hemispheres of the brain, focal seizures only involve one hemisphere. 2 primary subtypes are focal onset awareness seizures and focal onset impaired awareness seizures. The focal onset aware seizure used to be called a simple partial seizure. Here, the symptoms depend on where in the brain the seizure originates. If the seizure originates from the occipital lobe, for example, symptoms may be visual. If it arises from the precentral gyrus or primary motor cortex, symptoms might have more to do with rhythmic motor activity. And if it arises from the postcentral gyrus or primary somatosensory cortex, symptoms may manifest as sensory sensations like pins and needles. The second subtype of focal seizures is the focal onset impaired awareness seizure, which used to be called a complex partial seizure. This type of seizure often arises from the temporal lobe and has an added element of altered awareness or consciousness. This shows itself in purposeless movements, such as lip smacking, picking at clothing, undoing buttons, and so on. About 50% of individuals who experience this type of seizure have an aura, which is a warning that a seizure involving an altered state of consciousness is about to occur. The aura itself is considered to be a focal onset aware seizure. These auras remain consistent within an individual and may point to the focus of the seizure within the brain. Common auras include nausea, dizziness, numbness, hallucinations, unpleasant smells, and metallic tastes. As you can see, there are quite a few different types of seizures. People can actually have more than one type, and some people may start off with one type, then change into a different type over time. The frequency and the pattern of seizures can also change. Which brings us to our two case studies, both of which involve seizures that changed over time. Let's start with HM. Born in 1926, HM started experiencing absent seizures at the age of 10. By the time he was 15, these had turned into tonic-clonic seizures. It got to the point where he was having up to 10 tonic-clonic seizures a day. His seizures were so disruptive that he dropped out of high school, lived at home with his parents, and was unable to hold a steady job. Though HM had a history of epilepsy on his father's side and had sustained a minor head injury as a child, no definitive cause of his epilepsy was ever established. Turning to Christine, she was born in 1969 and experienced her first tonic-clonic seizure at the age of 19. She continued to have approximately one tonic-clonic seizure a year until she reached the age of 30, at which time she started to experience up to 15 focal onset impaired awareness seizures per day. She was also pregnant when this new seizure type appeared. Christine's husband, Jerome, knew when she was having a seizure, as she would utter the words, okay, okay, over and over again for about 35 seconds. She would then break out of this pattern and be confused for a short period of time. These seizures exhausted Christine and had a negative impact on her quality of life. Christine's epilepsy was believed to be caused by either cortical dysplasia, which is a prenatal condition in which developing neurons fail to migrate to their target locations, or a low-grade tumor in her right frontal lobe. A cyst was also discovered in her right temporal lobe, but it's unclear whether this contributed to the cause of her seizures. Let's now examine the causes of epilepsy and potential treatment options. In general, the causes of epilepsy are quite diverse. However, in most cases, a distinct cause is never identified. Many forms of epilepsy have a complex genetic basis with multiple gene defects that contribute to a state of altered cellular excitability, which, as we know, underlies epilepsy. Genetic abnormalities can occur anywhere from the circuit level, as with cortical dysplasia, to the receptor level, as with abnormal GABA, so inhibitory receptor subunits, to abnormal ionic channel functions, as with potassium channel mutations, which contribute to neuronal transmission. Another potential cause of epilepsy is prenatal issues, such as maternal infection, poor maternal nutrition, fetal oxygen deficiencies, and cortical dysplasia. Seizures are also associated with other developmental disorders, including autism and neurofibromatosis, which is a condition that causes tumors to form in the brain, spinal cord, and nerves. Infectious diseases, such as meningitis and viral encephalitis, can also cause seizures, as can vascular diseases, including stroke. Brain tumors and head injury can cause seizures to develop as well. There are many more proposed causes of epilepsy, and in most cases, doctors may be able to speculate about potential ones based on a patient's history, but trying to establish a definitive cause is extremely difficult. In regard to treatment, taking one or more anti-epileptic drugs is successful in about 75% of newly diagnosed patients with epilepsy. There are a wide variety of drugs currently on the market, and different drugs work for different people. Drugs used to treat epilepsy do one of the following things. 1, decrease electrical activity in the brain by blocking sodium or calcium channels, which play a crucial role in how neurons communicate with one another. 2, enhance potassium channel function, which also plays an important role in neuronal communication. 3, inhibit excitation mediated by the neurotransmitter glutamate, which plays a role in learning and memory. Or 4, promote inhibition mediated by the neurotransmitter GABA. Unfortunately, these medications can also have side effects, the most common being fatigue, and not everyone responds to them. For example, though both HM and Christine were treated with high doses of an anti-epileptic drug combination, their seizures continued. So what other options do patients like HM and Christine have? Well, in some cases, brain surgery can be performed to try and control seizure activity. In fact, brain surgeries to allay seizures have led to some of the most amazing discoveries about the human brain. The most consequential early surgeries occurred in the 1940s, when the first corpus callosotomy, also known as a commiserotomy or a split brain surgery, was performed. Recall that the corpus callosum, which contains 200 to 250 million nerve fibers, connects the two hemispheres of your brain. We know that sometimes a seizure can start in a very focal location, say a small area in the left temporal lobe, and then migrate through the corpus callosum to the other side of the brain, resulting in a generalized tonic-clonic seizure. So back in the 40s, as a means to contain seizure activity in one small area of the brain, doctors first cut the fibers of the corpus callosum, and the experiment was a success. After the surgery, patients typically experienced a significant reduction in their seizure activity and suffered no intellectual or emotional impairments. There was one significant drawback, however. Because the corpus callosum was severed, patients now felt as if they had two separate brains that could act independently of one another. I know that sounds kind of crazy, but this discovery led to groundbreaking research on the functional differences between our left and right hemispheres, which contributed greatly to our current understanding of the brain. In fact, in 1981, Dr. Roger Sperry from Caltech was awarded a share of the Nobel Prize in Physiology or Medicine for these discoveries. One of the first things that surgeons noted was that once corpus callosotomy patients had recovered from the surgery, many experienced what can only be described as conflict between their two hands. For example, one patient would go shopping at the grocery store, and it would take her hours because each hand would independently add items to her cart. Another patient had trouble picking out outfits to wear, as each hand would independently pick out one from her closet. This intermanual conflict was observed in a variety of situations, whether it be trying to take a hot dish out of the oven, answering the phone, or even turning the steering wheel in a car. Luckily, these issues disappeared with time, and the patient eventually appeared no different from anyone else in society. If you brought them into the research laboratory, however, you could still observe this conflict between the two hemispheres in their brain. One of Roger Sperry's graduate students, Dr. Michael Gazzaniga, conducted a variety of studies on hemispheric differences in split brain patients. Through this research, we gained a much better understanding of how, for the majority of people, language skills are a primary function of the left hemisphere, while visuospatial and facial recognition abilities are primary functions of the right hemisphere. In Gazzaniga's studies, a patient would be seated in front of a computer and asked to stare at a fixation cross in the center of the screen as images appeared on both the left and the right. These images flashed by so quickly that the image presented to the left of the fixation cross was only received and processed by the right hemisphere of the brain, and vice versa. Consider this example. A corpus callosotomy patient sits in front of a computer screen and is asked to stare at a fixation cross in the middle while two words are flashed on the screen. The word orange to the left and the word banana to the right. What word would the patient say they saw? Well, since the left hemisphere has language capabilities and processes images from the right visual field of vision, they would say they saw the word banana. Now, what if the patient was asked to reach their left hand under a curtain and select by touch the object that they saw? Since the left hand is controlled by the right hemisphere of the brain, and that side processed the left field of vision, their left hand would select an orange. So to recap, a split brain patient would say they saw the word banana, but would physically select the orange when using their left hand. Each hemisphere sees something different. And because the corpus callosum was cut, each hemisphere cannot tell the other what it sees. Fascinating, right? Now, what would you suppose would happen if we did this experiment with you, assuming you have an intact corpus callosum? Well, your left hemisphere would tell your right hemisphere it saw the word banana. And your right hemisphere would tell your left hemisphere it saw the word orange. So if I were to ask you what word you saw, you would reply both banana and orange. And if I had you use your left hand to choose the object you saw underneath a curtain, you would pick up both a banana and an orange. Make sense? Although surgery on the corpus callosum is extremely rare these days, as this example shows, it did make a significant contribution to the field of neuroscience. Now let's return to HM and Christine. Though neither of them had a corpus callosotomy, they did have different kinds of brain surgeries, and the results can tell us a lot about how the brain works. Let's start with HM. In 1953, neurosurgeon William Beecher Scoville made the decision to perform an experimental brain surgery on HM to try relieving him from his seizures. The surgery, known as a bilateral mesial temporal lobe resection, involved removing large areas of HM's temporal lobes on both sides of his brain. In the 1950s, we really didn't have a good sense of the function of the temporal lobes, which today we know are essential to memory formation. So while HM's seizure activity was significantly reduced by the surgery, though he still had to remain on anti-epileptic medicine, he also lost a lot of his long-term memories and became unable to form any new ones. Now let's take a look at Christine's surgery. In 2002, doctors used magnetoencephalography, or MEG, to pinpoint the location of Christine's seizures, and they discovered an abnormality in her right frontal lobe. They decided to remove this brain tissue through a brain resection in an effort to decrease or eliminate Christine's seizures. During the surgery, doctors discovered a cyst in Christine's right temporal lobe and decided to remove it as well. In the end, doctors removed brain tissue about the size of a golf ball from both Christine's right frontal lobe and her right temporal lobe. A biopsy of this tissue suggested that the abnormality in her right frontal lobe was a low-grade benign brain tumor. Doctors also thought cortical dysplasia was involved. This surgery was successful in controlling Christine's seizures, though she does still take anti-epileptic medications. Today, she only has about one generalized tonic-clonic seizure every 3 years and no complex partial seizures. She does, however, have some neuropsychological deficits that we'll get to in a moment. Although corpus callosotomies and resective surgeries continue to be performed, we now have other options available for patients that are less invasive. I wanted to briefly mention 4 of them: laser interstitial thermal therapy, responsive neurostimulation, or RNS therapy, vagus nerve stimulation, and deep brain stimulation. Laser interstitial thermal therapy involves using a laser to pinpoint and destroy small amounts of brain tissue where the seizures originate. Surgeons use MRI technology to guide them through this process. RNS therapy is a bit like a heart pacemaker. Here, a device is placed within the skull, and tiny wires or leads are placed in 1 or 2 spots on top of the brain where seizure activity is believed to begin. These wires connect to the device, which monitors brain waves at the seizure focus point 24 hours a day. When the device detects unusual electrical activity that can lead to a seizure, it responds quickly, within milliseconds, by giving small bursts or pulses of stimulation. This stimulation helps brain waves return to normal before they can turn into a seizure. In vagus nerve stimulation, a device is implanted under the skin in the left chest area, and an electrode or wire is attached to the device and placed under the skin. The wire is attached or wound around the vagus nerve in the neck. The device delivers pulses or stimulation at regular intervals in the hopes of preventing or reducing seizures. Although it's not exactly clear how vagus nerve stimulation works in the brain, it is designed to change how brain cells work by sending electrical impulses to certain areas involved in seizures. Finally, deep brain stimulation also uses an electrode to release regularly timed electrical signals that disrupt abnormal seizure-inducing activity. The electrode is permanently implanted deep inside the brain, and the generator that sends the electrical pulse is implanted in the chest. So as you can see, there are a variety of options available to epileptic patients who have trouble controlling their seizures with anti-epileptic medications alone. In general, the neuropsychological deficits that accompany epilepsy are highly individualistic. It depends on what brain areas are affected by the seizures, the type of seizures, how long the seizures last, and how often they occur. Some people never develop any type of deficits, while others suffer from attention and memory problems, especially difficulty retrieving words or anomia. Cognitive functioning appears to be more greatly impaired in individuals who have had seizures for a longer period of time and in individuals who experience seizures more frequently. As HM surgery showed, we should never, ever simultaneously remove both hippocampi. Remember, you have one in the left temporal lobe and one in the right temporal lobe. When HM surgery was performed, we didn't know the function of the hippocampus. As we now know, the hippocampus enables us to form long-term declarative memories, so memories for people, facts, and events. And without it, we can't do that anymore. HM could not form any new long-term memories after his surgery, a condition known as anterograde amnesia. People can have different levels of anterograde amnesia depending on how badly the hippocampi are damaged and whether just one hippocampus or both are affected. HM had severe damage to both hippocampi, leaving him unable to form any new declarative memories. Imagine if, starting at this moment, you could no longer form any new memories. Within seconds, you would forget anyone you met, anything you saw, anything you read, any conversation you had, and anything you did. Nothing would stick in your brain. You'd be living an ever-repeating moment in time. Memories associated with all sensory modalities would be affected. So touch, taste, smell, hearing, and vision. In addition to anterograde amnesia, HM also suffered from retrograde amnesia, which is the loss of long-term memories that have already been formed. Retrograde amnesia varies in temporal extent. Some people lose years' worth of memories, some months, some days, and some just hours, as is the case when someone gets into a car accident and does not remember what happened just before, during, or after the accident occurred. HM ended up losing 11 years worth of his long-term memories. He had surgery when he was 27 years old, so he lost most of the memories that he formed between the ages of 16 and 27. Of interest is that HM's intellect, general knowledge of the world, and personality remained intact, and his language skills were sharp. His short-term memory and procedural memory skills were also intact. How could this be? Well, remember that short-term memory skills, so holding information in storage for a few seconds, are mediated by the frontal lobes. And procedural memory skills, like learning how to ride a bike, are mediated by the basal ganglia system. Neither of these brain regions were affected by HM's surgery. Over the course of his life, HM was studied by over 100 scientists, most notably Dr. Suzanne Corkin from MIT. But because of his severe memory deficits, he had no idea how famous he was. He died in 2008. Christine also experiences memory deficits, although not to the same degree as HM did. Her deficits are more sporadic. Sometimes she remembers things, and sometimes she doesn't. So, for example, she might be able to tell you about her bowling game the night before, but she might forget her husband has a golf game, even though he's told her multiple times. Christine also experiences issues related to frontal lobe functioning, such as mood changes leading to angry outbursts and depression, irrational thoughts, lack of initiation, working memory deficits. So she has trouble balancing a checkbook, difficulties with multitasking, and even slight personality changes. She appears less sarcastic and more laid back post-surgery. These issues affected her ability to hold down a job in the years following her surgery. After losing a few jobs due to her difficulties, she decided to go on disability. It's important to keep in mind that life after brain surgery for people with epilepsy can be a long and frustrating experience, both for the patients and caregivers. Although Christine's husband Jerome had done his research and knew just how serious her operation was, he was not made aware of the potential cognitive and emotional ramifications. Christine's angry outbursts, depression, and irrational thoughts were hard for him to deal with, and they had to seek out multiple doctors and try a variety of medications before her mood became more stabilized. Had Jerome known what to expect, he could have been more prepared for these symptoms and had a better understanding of what he should do. Jerome advocated for Christine and was patient as they sought out a variety of potential treatments. It took years, though, for Christine to reach a point where she felt more like her old self again. Hopefully, with continued research and scientific advances, individuals with severe epilepsy will be able to lead normal, fulfilling lives sooner rather than later.